Today, we are going to discuss EMS documentation, an essential aspect of our jobs. Good documentation is not just paperwork, it is a critical part of patient care and professional practice. In this series, we will explore why accurate, thorough documentation matters for patient outcomes, legal protection, billing, research, and quality improvement. We'll also cover best practices for writing patient care reports, PCRs, including how to document times, refusals of care, and narratives using formats like SOAP and D-chart. By the end, you should understand your legal and ethical responsibilities in documentation and feel equipped to paint a clear picture of every patient encounter in your reports. EMS documentation is an integral part of the patient care process. Whenever you respond to a call, the information you record becomes part of the patient's permanent medical record and the emergency department's chart. This written record communicates your findings and care to hospital staff and other providers who continue treating the patient. In other words, if you didn't write it down, it effectively didn't happen as far as the medical record is concerned. Proper documentation ensures continuity of care. It helps hospital staff understand what happened before the patient arrived, what treatments were given, and the patient's status. It also serves as a communication tool during handoffs, making sure no critical information is lost. Always remember that your PCR might be read by nurses, physicians, specialists, or another EMS crew on a transfer. They rely on your words to make appropriate decisions for the patient. In addition, your documentation isn't just used immediately, it is stored and may be referenced later. The PCR becomes a part of the official record of the call, which could be reviewed for billing, quality improvement, or even legal proceedings months or years later. Because of this lasting impact, documentation is as important as any clinical skill you perform on scene. It is a reflection of your care, your professionalism, and your attention to detail. Your patient care report is a legal document, and there are important legal implications to consider. First, everything you include must be truthful and based on what you observed or what the patient told you. It's acceptable to include subjective statements from the patient. For example, patient states, "I feel dizzy," but you must avoid inserting your personal bias or unsupported opinions in the report. Never guess or exaggerate. For instance, do not write, "Patient is drunk," which is an opinion. Instead, document objective observations like, "Patient had slurred speech and smelled of alcohol." Stick to the facts, what you saw, heard, did, and what the patient or others said. Inaccurate or biased documentation can not only mislead other healthcare providers, but it can also come back to haunt you legally. Remember the saying, sloppy documentation implies sloppy care. If your report is disorganized, incomplete, or full of errors, it gives the impression that you were careless with the patient's treatment as well. Omissions and mistakes in PCRs can lead directly to errors in patient care because subsequent caregivers might not have the info they need and can open the door to litigation against you or your agency. In a worst case scenario, bad documentation could cost you your job or certification and damage your reputation. To underline the legal importance, consider a real example. In the case D. Tarquino versus Jersey City EMS, a patient with a head injury was transported to a hospital and later died of a brain bleed. The EMS crew failed to document that the patient had vomited during their care. Vomiting in a head injured patient is a critical sign that could indicate increasing intracranial pressure. The lawsuit argued that if this had been documented, the hospital might have recognized the severity and not discharged the patient so soon. The court found that negligent documentation can be considered a form of negligence separate from the patient care itself. In other words, even if your treatments were appropriate, failing to document important information is legally actionable on its own. This case warns us that there is a distinct standard of care for documentation. You must meet that standard every time. Proper documentation isn't just about patient care, it's also crucial for billing and administrative requirements. EMS is often reimbursed by insurance like Medicare, Medicaid, or private insurers, and those payers have specific documentation requirements. To ensure timely and correct billing, always document all procedures and interventions you performed, no matter how basic. If you splint an arm, start an IV, administer oxygen or medications, it all needs to be recorded. Insurance will only pay for services that are documented. If it's not on the PCR, from the payer's perspective, it didn't happen and thus isn't billable. Thorough documentation helps your billing department justify the level of care provided and the charges billed. For example, Medicare and other insurers require proof of medical necessity for ambulance transport. This means your PCR must clearly state why the patient needed an ambulance instead of a taxi or other means. Document the patient's condition and circumstances that made the ambulance necessary, such as they were found immobile on the floor or they needed continuous oxygen and monitoring. Include the reason for ambulance transport in your narrative. Patient required continuous cardiac monitoring and could not safely be transported by private vehicle. Many PCR forms have a section for medical necessity where you should describe the situation in detail. Additionally, obtain the required signatures for billing. Often, you'll need the patient's signature or that of a guardian or physician on a form to confirm medical necessity or to authorize billing. For instance, Medicare often requires a patient's signature or that of a receiving facility physician to verify that transport by ambulance was required. If the patient is unable to sign, follow your agency protocol. Usually, another authorized signer or a reason why the patient couldn't sign is documented. Failing to get these signatures can delay or prevent your service from getting reimbursed. In summary, complete every section of the PCR and ensure it meets billing requirements. This protects your agency from lost revenue and even potential accusations of fraud. Complete documentation equals faster, smoother reimbursement, and it ensures compliance with insurance and legal standards. Beyond immediate patient care and billing, your documentation contributes to the bigger picture of EMS research and system improvement. Many states now require EMS agencies to submit patient care data to a central database at the state EMS office. These records, often stripped of personal identifiers, flow into the National EMS Information System, NEMSIS, which is a nationwide data repository. NEMSIS collects standardized EMS data from all over the country. The goal of NEMSIS is to use this massive data set to define and improve EMS care by identifying trends, outcomes, and best practices on a large scale. For example, by aggregating thousands of PCRs, researchers and policymakers can analyze response times, treatment effectiveness, and patient outcomes. They can ask questions like, what is the national survival rate for out of hospital cardiac arrest when certain interventions are used? Or, how often are certain medications being given and are there regional differences? Data from NEMSIS helps in developing better protocols, training, and policies based on evidence. It also assists in evaluating system performance, like how quickly ambulances respond, and identifying areas that need improvement or additional resources. In practical terms, this means when you fill out all those data fields in an EPCR, patient age, vital signs, procedures, outcome, etc., that information may be anonymously contributing to research that shapes the future of EMS. Patient care data collection can improve the EMS system as a whole. It's not just bureaucracy, it has a purpose. So take data entry seriously. By ensuring accuracy and completeness, you're playing a part in a nationwide effort to improve pre-hospital care. The saying for NEMSIS is better data, better care, highlighting that the quality of care can be defined and enhanced through the quality of our documentation. Your PCRs will also be used for incident review, quality assurance, called QA, and continuous improvement within your service. Supervisors, training officers, or medical directors may review reports for medical audits or case review sessions. This is not meant to nitpick, but to ensure protocols are followed and to identify areas for improvement or training needs. For example, a QA committee might pull a random selection of cardiac arrest calls to see if high performance CPR standards were met, using the documentation to evaluate things like timing of interventions or if all required assessments were done. PCRs are often used to track your clinical experience as well. For instance, an agency or state might keep a record of how many times you performed certain skills like intubations, IV starts, or medication administrations. They derive those numbers from your documentation. If you attempt a procedure but don't document it, it's as if you never did it, which can affect not only patient care but also your credentialing or future opportunities. Always accurately document any skills attempted and performed, including the outcome. Even if a skill was attempted unsuccessfully, it should be noted. Like, I attempted 4 in left ACX2 unsuccessful, then 4 in right hand successful. In one legal case, an EMS crew failed to document their failed intubation attempts, and the court saw those omissions as evidence of deviating from protocol, essentially gross negligence. The lesson is document everything you did or tried to do for the patient. This not only protects you legally, but also provides honest data for quality improvement. EMS agencies also use PCRs for training and education. A particularly challenging or interesting call might be reviewed, with identifiers removed, in a team meeting to discuss what went well or what could be done differently. If your documentation is detailed, it allows everyone to learn from that call. Conversely, if the report is scant, the learning opportunity is lost. So think of documentation as contributing to the knowledge base of your team. No matter how minor or major the call, every EMS call must be documented. There is a concept of a minimum data set, which are the standard items that should be documented on every single call, no exceptions. Essentially, this breaks down into two categories: run data and patient data. Think of run data as the information about the call itself, the administrative and operational details, and patient data as the information about the patient and the care provided to them. Run data typically includes things like the call incident number, unit number, names or IDs of crew members, the times of key events, and the addresses or locations involved. It also can include the responding agency information and sometimes elements like weather or scene safety notes. These are generally facts about the response. They answer who, when, and where. Patient data includes the patient's identifying and medical information. For example, the patient's chief complaint, in their own words if possible, what prompted 911, the patient's level of consciousness or mental status, a set of vital signs, ideally multiple sets, to show trends, assessment findings from head to toe, patient history like their medical history, medications, and allergies, and demographics like age, gender, and any other pertinent info. Basically, it covers what we found and what we did for the patient. On every call, even those that seem routine, you should document all the minimum data set elements. For example, even if you're just evaluating someone who ultimately isn't transported, you still record the time you were dispatched, the crew members, the patient's vital signs, your assessment, and so on. Completeness is key. Standardization helps too. Many PCR systems enforce that you fill these required fields. This consistency ensures that if your report is later pulled for review or sent to a receiving facility, all the critical information is there. Let's break down those components further. Run data often starts with documenting all relevant incident times. EMS operates on precise timelines, and we need to capture each significant timestamp. You should record times such as time of call, time of dispatch, or when your unit was alerted, time of arrival on scene, time of patient contact if different from arrival, time any critical interventions were performed, time of departure from scene, time of arrival at the hospital or destination, time of transfer of care, and time back in service. All times should be documented in military time, a 24-hour format, to avoid confusion between AM PM. Accurate timekeeping is essential for creating a clear timeline of events. Modern EPCR systems often auto populate some of these times, but you must verify them for accuracy. If you manually write times, double check them. Nothing looks sloppier than impossible time sequences, like recording a treatment before you even arrived. If there was any delay or unusual timing, you can note an explanation in the narrative. Run data also includes locations and identifiers, the address of the incident scene, and the destination hospital name or address. Make sure to spell these out clearly or select from drop down lists correctly in an EPCR. Also list the responding units and crew members. Usually, you would put your ambulance unit number and perhaps any other agencies involved fire, police, backup ambulance, etc. Crew names, certification levels, or ID numbers should be included as required by your service. This establishes who was on the call, which can be important later for QA or legal review. It also provides contacts if someone needs more information about the case. Now for the patient data portion. Start with the chief complaint, which is the reason the patient or someone on their behalf called for help. It's best to phrase this in the patient's own words if possible, like, I have chest tightness, or I have fell and can't get up. This ensures we capture their perspective. Next, document the patient's level of consciousness or mental status upon your evaluation. Mental status is crucial because it affects decision making capacity and indicates how sick the patient may be. You'll also record vital signs and assessment findings. Vital signs typically include blood pressure, heart rate, respiratory rate, oxygen saturation, and maybe blood glucose, temperature, or pain scale as appropriate. If you have multiple sets of vitals, which is ideal to show trends, include all of them with times. In the narrative or dedicated fields, record your assessment of the patient, both the primary survey or ABCs and a secondary head to toe if performed. Document pertinent positives, the abnormal findings, and pertinent negatives, the things you checked for and didn't find. For example, if the patient had chest pain, you might note a pertinent negative like, no difficulty breathing noted to show you assessed that. In fact, documenting pertinent negatives is a good habit. If you don't write that you checked something, reviewers might assume you didn't. Finally, include patient demographics, name, age, or date of birth, sex, and any other identifier required. Often, this is in drop down fields. Also, note the patient's medical history, medications, and allergies. These might be on a separate section, but is still part of the patient information you gather. All this patient data combined with the run data and narrative forms a complete picture of the call. Transfer of care is a crucial moment in patient management, and it must be properly documented to protect both the patient and you as a provider. When you arrive at the hospital, or whenever you hand the patient off to another healthcare professional or transport unit, you need to document in whose care you left the patient. This typically means recording the name and title of the person who assumed responsibility for the patient. For example, patient care transferred to Jane Smith RN in ED room 5 at 1822. This line in your PCR is extremely important for legal reasons. It demonstrates that you did not abandon the patient. Transfer of care documentation is not only for hospital handoff. If you ever transfer a patient to another EMS unit or service, for example, handing a patient to an incoming ALS intercept or to a medevac helicopter crew, or if you're an EMT turning over to a paramedic unit, you also need to document that exchange. Write the time and to whom you transferred the patient, include their name and certification or agency. Why is this so critical? Apart from the ethical duty, consider an unfortunate scenario. An EMS crew once left a patient in a hospital waiting area without directly handing off to medical staff. They noted the arrival time but did not ensure a proper transfer. Tragically, the patient was found dead in the waiting area about an hour later, and because there was no clear handoff, the EMS service was implicated in a wrongful death lawsuit. This illustrates that failing to explicitly transfer care and document it can have dire consequences. It's not enough to assume the hospital knows the patient is there. You need to actively transfer and document it. So, best practice: never leave a patient until you have given a verbal report to a qualified healthcare provider and that person acknowledges they are taking over care. Document that person's name, ask for it if needed, and spell it correctly, and title, along with the date and time. This small detail in your report can protect you from allegations of abandonment. It's part of closing the loop on the call and ensuring continuity of care for the patient. When you arrive at the scene of an emergency, sometimes things have already been done for the patient before you got there. It's important to find out about any care provided prior to your arrival and document it. This could include instructions given by the dispatcher to a 911 caller or actions taken by bystanders, family members, or off duty medical professionals at the scene. For example, dispatch may have given pre arrival instructions such as CPR, bleeding control, or use of an EpiPen. When you take over patient care, ask what, if anything, was done before you arrived. Common scenarios may include a family member started CPR, a bystander controlled bleeding, the patient took some self administered medication like nitroglycerin while waiting, or perhaps an off duty provider on scene initiated care. You should document each of those interventions and who performed them as best you can. For instance, bystander CPR was in progress upon EMS arrival per family. CPR started about 5 minutes prior. Or, patient's wife administered patient's prescribed nitroglycerin at 14:10 prior to EMS arrival, with no relief of chest pain. If a law enforcement officer or off duty EMT applied a tourniquet or gave naloxone, include that information. Tourniquet applied to patient's left leg by off duty EMT before arrival, time approximately 8:30, bleeding was controlled. This documentation provides context for the patient's condition when you find them and helps the receiving facility know the full timeline of care. Also, if any of that prior care was done incorrectly, or if you needed to change it, document your corrections in a factual way without blaming. For example, dispatcher instructed bystander CPR in progress, compression rate noted to be slow, EMS took over and performed high quality CPR. Or, patient had been placed in a seated position by family. Upon arrival, patient repositioned supine for better assessment. The goal is to record what was done and what you found, not necessarily to critique it, but any relevant impact on patient care should be noted. Documenting prior care is important for a few reasons. Clinically, it helps determine what effect those actions had, did the patient improve, etc. Legally, it shows you recognized and accounted for those actions. If a complication arose from something a bystander did or didn't do, having it in the record is important. And ethically, it acknowledges the efforts of others in the chain of survival. Join me in the next lecture for more documentation information.